Hi, this is Dr. Neurosurgery Greenberg, and we are going to talk about the evaluation of pituitary tumors. So, first of all, you have to do a proper history and physical of the patient, and after that, you come to know that okay, this might be a case of a pituitary tumor, and the endocrine signs and symptoms are there. Now, you have to confirm it, and if, of course, because of pituitary adenomas, some kind of visual field deficit is going to come. But you have to counsel older patients and those patients with a visual field deficit more than 4 months that if you do surgery or medical, whatever treatment you do, the chances of return of vision are reduced. Even with surgery, they are reduced. Okay, so you have to already counsel them that we will give our best, but it is a little bit late. Next, there is a schema that is given in our beautiful Greenberg book. But in order to understand that, we have to go through the whole chapter first. So, first of all, you need to know that how do you test the visual field? What is the visual field? The visual field is whatever you can see with both of your eyes. And usually it is 60-degree inferior, 70-degree superior, 60-degree nasal, and 100 degrees on the temporal side. And this is the normal visual field. It is checked by perimetry. Either you do it in front of the patient, you do a confrontation method, or you do with the Goldman perimetry, or there is digital as well. Whatever you use, you have to look at the pattern. So in the classic pattern in which the pituitary is lying, the chiasm is lying just above the sella. Then if there is a pituitary adenoma, it will compress the chiasm. The nasal fibers will be compressed and a classic bitemporal hemianopia will be produced. But now, if the chiasm is behind the sella, then it is a post-fixed chiasm. And now the lesion will actually involve the optic nerves and lead to total blindness. But if the chiasm is in front of the sella, then the lesion will be compressing the optic tract. And here the lesion will be a homonymous hemianopia. And one more thing that when the lesion is behind the sella, which is called post-fixed chiasm, then not just the optic nerve, but another part of the chiasm called the anterior band of Willebrand, which are the nasal fibers from the contralateral optic nerve, they are also compressed. So here, not just blindness of that ipsilateral eye, but a superior quadrant, temporal quadrant anopsia will also be there. And this is called a junctional scotoma. It is seen in post-fixed chiasm. And the prefix, you already know that optic tract will be involved and you will have contralateral hemianopia. So there are other tests as well, like ancillary visual testing. You can do OCT. It is just to look at the retina and it is just for prognostic information. Then we come to the major topic, which is the endocrinologic evaluation or screening. You have to look whether there is under secretion or over secretion of hormones. So first of all, you have to look at the cortisol reserve. In the cortisol reserve, you do the co-syntropin stimulation test. Co-syntropin is just like an ACTH. Okay, so you give ACTH, and before giving the ACTH or co-syntropin, you take a baseline cortisol level, whatever, whether fasting, non-fasting, it doesn't matter. Then you give the ACTH, and then you again check the cortisol levels after some time, like 1 hour, half hour. In the normal response, when you give ACTH, the cortisol will peak. Its level will be more than 18 millicentigram per deciliter, and there will be an increment of more than 7 millicentigram per deciliter. That is, the peak will be more than 18 and the increment will be more than 7. Or overall, the peak will be more than 20 regardless of how much the increment is. So that is a normal response, that more cortisol will be secreted. But in a patient in whom there is cortisol deficiency, now you have to remember that there are two types of pituitary adenomas. One that are tiny and they are secreting the ACTH. They are causing hypercortisolism. But most of the tumors are non-functioning. We know that most common pituitary tumors are non-functioning. So here they are going to depress the pituitary stalk. They are going to stop the stimulatory factors coming from the hypothalamus to the pituitary. So overall, the body will be depressed in ACTH and sometimes even TSH. And this is a very critical situation, because if there is any kind of stress like infection, surgery, whatever, hypoglycemia, then the body is unable to meet the metabolic demands of that stress. So that means that the patient is very vulnerable, and he can actually even die. So in that case, you have to check if the patient is able to produce more cortisol when needed, or if you have to provide external steroid. So in this test, when you give ACTH, there is no peak. Okay, the peak is less, and this means that there is primary adrenal insufficiency. And so this was one of the tests. Then there is another test which is the gold standard for looking at how good the hypothalamus, pituitary, and adrenal axis is. This is called the insulin tolerance test. So in this, you are again going to stress the patient. What you will do is that you will give insulin. Insulin will lead to hypoglycemia. Hypoglycemia is a stress-like situation for the patient. You have to do hypoglycemia up to less than 50 milligram per deciliter of blood sugar. And when that happens, you have to check the cortisol, that how much after the hypoglycemia, how much cortisol has risen. If in normal patient, the cortisol increment will be more than 6 microgram per deciliter up to a peak of more than 20. But if the peak is between 16 to 20, then you will have to give stress doses of steroid. But if it is even less than 16, then you have to replace the corticosteroid at anyhow for lifetime. Okay, so this is the gold standard. After you have determined that there is need of there is actually adrenal insufficiency, you have to do the screening tests. In the screening tests, you can do, one is the 8 a.m. cortisol. Again, it will tell you about whether the patient has hypocortisolism or not. Usually at 8 a.m., cortisol level is at its peak. But here, even when the cortisol is supposed to be at the peak, because there is insufficiency, then the peak will be low. So what is the normal value? The normal value is 6 to 18 microgram per deciliter of cortisol is the normal value. So if at 8 a.m. the cortisol is even less than 6 microgram, it means that there is adrenal insufficiency, and you have to confirm that hypocortisolism is there. Then 8 a.m. cortisol is between 6 to 14. It is a gray area. You have to do it again. Then it is more than 14 microgram per deciliter. Then the patient is fine. He is not hypo. There is no hypocortisolism. Then there is another test which is for hypercortisolism, and that is 24-hour urine free cortisol. You just check how much the value is. Okay, and if so, that is all about evaluation of the pituitary adenomas for now. I will see you in the next video with the remaining portion of this chapter, which is the evaluation. And thank you so much, and God bless you.